All right, well, hopefully, if there were people on Facebook that wanted to watch and didn't register, they can go on YouTube Live. And it is, let's see, we're setting up for YouTube Live, so we should be pretty good there, I hope, if that doesn't crash. And then later, the goal, I can try and post it on, if there were people on Facebook, I can try and post it on Facebook afterwards. Okay, so looks like we're live on YouTube. We are all here. Looks like we have already 13 people that have joined, which is great. We're going to give it 2 more minutes and then we'll get started. In the meantime, let me just post on Facebook that we are live on YouTube. Okay. All right. Okay, so it looks like we have a couple more people that joined. So in the bottom of the screen, you guys can see that there should be an icon where you could either Q&A, ask a question, or you can potentially chat, one or the other, or maybe both. So as questions come up, feel free to ask, and then we can address them at the end. Okay. All right, so let's see. I'm going to share my screen in a second. And let's try it. Okay. All right, so I think we can get started. For those of you that are on here that don't know me, my name is Dr. Alex Voldman. I'm an ophthalmologist, and I have a particular interest in cataract and cornea surgery and laser refractive surgery. And the impetus for doing this first webinar for our practice was really because for the last few weeks, as we haven't been working much, I've been doing a lot of webinars and educating myself and learning new surgical techniques and technologies that are out there. And it's been really the best part of the quarantine for me. So I figured, why don't I share some of the things that I know with our current and future patients, and we can have a discussion. And sometimes in the busyness of a regular clinic day, when patients come see us for consultations, we don't get a chance to talk as much as we would like and share all the things we know. So this might be a platform for that, and it'll be recorded. And so we'll be able to direct patients there in the future. I have been in practice for over about 3 years with eye physicians and surgeons. And we are a group of currently 9 docs where we cover all the subspecialties in ophthalmology, pretty much from oculoplastics with Dr. Silverstone, Dr. Bacall doing pediatrics and strabismus, adult strabismus and double vision surgeries. Dr. Meskin, who's on with us today, is an expert corneal surgeon and cataract surgeon. Dr. Levinson is our retina specialist. Dr. Faridi also does cataract surgery as well as glaucoma. Myself, and there's Dr. Galvin, who recently joined. She also does pediatrics, adult strabismus, and Dr. Bowen is our current optometrist. And we hope to be having another one in the future. So my objectives here today is to talk about what a cataract is And then we'll talk about how surgery has advanced over the years, what's new in technologies, and we'll talk about what our practice looks like today. Today's April 23rd, and every day things are changing with how we're practicing. So let's start with what a cataract is. I'm going to first share, you guys should be able to see this screen here. So here's a picture of an eyeball looking directly at us, or an eye looking at us, or a face. If we turn the face or the eye to look in this direction, it's looking towards the left in my screen. And if we zoom out a little bit further, we can look at the whole eye. So the parts of the eye that are very important for this talk, the front part of the eye here in red, that's called the cornea. That's the clear front window to the eye. Inside the eye is our natural lens. Everybody has a natural lens that they're born with. We call this a crystalline lens or a natural lens that helps us focus light. And in the back of the eye here in blue, well, that is the retina. And if when you go to the eye doctor, sometimes they put drops in, and the drops are there sometimes to dilate your pupil so we can look in the back of the eye. When we look in the back of the eye, this is what we see. We see these blood vessels, and these are normal. Everybody has those. We see this yellowish white ring here we call the optic nerve, and this is what sends messages from the eye to the brain. And we see the retina, and the center part of the retina here, which we're always concerned about, which gives us our sharpest vision, is called the macula. And the macula sends messages to the nerve, and if we zoom out further, this nerve, which we see here, sends messages to the brain, and we really see with our brain. So what is a cataract and how is it involved in all this? Like I said, the cataract is this central part here, the lens. And as the lens gets cloudy, we call that a cataract. So here's a clear lens, and here's a lens getting cloudy. And everybody eventually will get a cataract if they live long enough. The first signs of a cataract, and when the cataract first starts, some people might not notice anything, and that's probably the majority of people in their 30s, 40s, and 50s have very early changes to their lens that they just might not notice. The other things, once we get a little bit closer to our 60s or the cataract gets more mature, some people notice they need more light to read, or they sit next to a window because they need more light. The next thing people notice is that their prescription often starts to change, and they often complain that their nighttime vision is not as good. And that's when the cataract usually advances more. And at some point, the cataract gets to the point that no matter what pair of glasses we put in front, let's make that a different color, no matter what pair of glasses or contacts you put in front of the eye, light coming in gets blocked by the cataract. And if the light doesn't get to the retina and then the nerve and to the brain, you can't see very well. And that's when we come in to talk about possible cataract surgery. So let's go back here for a second. So what is cataract surgery, and what is it like, and what has it been like? This is an image from the 5th century BC of a man named Shishruda. And this is a particular technique, one of the first techniques, probably the first technique of cataract surgery, where you see this gentleman here with a sharp object pointed at the eye, where what he's aiming to do is a procedure called couching. And what he's doing is he's taking a sharp object and pushing the lens that I just showed you in that image, in that animation, and pushing that lens further into the back of the eye to clear the pupil so that light can go through. There's no more lens. But what happens with this lens is that the lens stays in the eye. So if you have a really dark lens that you can't see through, it's better to have no lens. At least you get light into the eye. But this really doesn't help you focus light, because remember we said the function of our natural crystalline lens is to help focus light. And if you don't have a lens there, you can't focus. Now, later in the 1700s, a French ophthalmologist named Jacques Daviel came up with a surgical technique which we called extra cap or intracap surgery. It's really intracap surgery where we remove the cataract from the front of the eye. Instead of pushing the lens in the back, we made incisions in the eye and we removed the lens from the front. And this proved to be likely a better technique, but there are downsides. When you make incisions anywhere in the body or in the eye, the larger the incision, the longer it takes to heal, and the weaker that structure is. So if you make a really big incision in your eye, the strength of the eye is weaker and it takes longer to heal. It might never heal properly. It might heal with scarring or heal irregularly. And it's important to have the eye nice and round. That's what gives you the really sharp image that we're always looking for. So this was a technique that was used for many years. Intracap cataract surgery would remove the lens from the front of the eye. Now, remember we talked about we're not putting any lenses in. So what are these patients doing? The ones we've pushed the lens further back or removed the lens from the front? Well, if they don't have a lens, they either can't see anything sharp, they can only see shadows and movement, which might be better than what they had, or they might need to wear glasses. And the kind of glasses you need if you do not have a lens inside your eye are a really thick pair of glasses that you see people wearing, those thick Coke bottle pair of glasses, because that lens needs to help focus light that's replacing the lens that was inside your eye, but the lens has to be very thick. The other downside to having such thick glasses is that the quality of the image is distorted. But it's really not an ideal way to improve somebody's vision. Until 1949, Sir Harold Ridley, a British physician, came up with the idea that we could implant a lens in the eye. We remove a lens from the front, but now we could put a lens in. And he came up with this idea actually from planes in World War II, where pilots had bits of the, not the glass, but it's a type of plastic that covers the cockpit of the fighter plane. When that plastic got into the eye, he noticed that it didn't cause a reaction in the eye. Maybe the plastic is safe. And this is the basis for how all of our lenses are made today. So now everybody nearly gets a lens implanted in their eye at the time of cataract surgery, so that they don't need to wear really thick glasses. And the technology has evolved significantly to the point where some people don't need to wear glasses at all. These lenses have really changed the practice of cataract surgery. So the first lens was put in around 1949, and today in 2019, you can see we have all of these different types of lenses where patients might not even need to wear glasses if they choose not to. Later, this is around 1980s, a physician named Charles Kelman invented something called phacoemulsification. This tool here that you see in the hand looks like a dental instrument. It's very similar to it, where the instrument actually divides the cataract into little pieces, and bits of the cataract are removed. And this is how cataract surgery is essentially done in the United States. Nearly all surgery is done with the use of this tool. And the goal of this tool was so that we don't need to make a big incision to remove the lens. Remember, we said big incisions need lots of time to heal, and they decrease the integrity and the strength of the eye. And you generally want a smaller incision because you can heal faster and have faster, better visual outcome. Most of our patients who have cataract surgery are back to desk work the next day. So this is really thanks to the invention of this phacoemulsification. Around this same time, in Moscow, a famous ophthalmologist named Fyodorov, who created a technique called RK, was also thinking of ways to optimize cataract surgery, make it safer, better for patients with faster recoveries. And I show this interesting video here where you can see a glimpse into the operating room around that same time when Dr. Kelman created the phacoemulsification. Dr. Fyodorov had the idea of creating an assembly line. And the goal is to have the most efficient, fastest surgery. So patients lay on a conveyor belt, and each doctor does one step of the surgery at a time. Here, they're either doing cataract surgery or RK surgery. And obviously, this is pre-COVID-19 times. We would never have something like this today, or never had that here, as far as I know. But again, the reason I show this is that we've been striving to have the safest, fastest, most efficient surgery for our patients for many years. And this was another step probably in the right direction. So today, nearly 100% of all cataract surgeries are done with phacoemulsification. Now, patients often ask, what do you do in actual cataract surgery? Are you taking my eye out? What's actually happening? So we often get students in our operating room that come to visit, and they want to learn about the steps of surgery. So I often describe it as disassembling a peanut M&M. So here's a M&M. The outside of the M&M has this candy shell. The inside has the chocolate, and then there's the peanut part. So the way that we essentially do cataract surgery is we make small incisions in the eye so we can get to the peanut. We make an opening in the top of the peanut. We use this tool, the phacoemulsification instrument, to disassemble the cataract or make it into smaller pieces. We remove those pieces, and then we remove the bits of chocolate, and we implant a lens. So let me show you maybe a nicer way to see that. So again, we make the incisions in the eye. We make an opening in the candy shell on the outside of the eye. And once we remove the candy shell, we can use our phacoemulsification to disassemble the lens or make it into smaller pieces, because remember, we have a small incision. We want small pieces to come out of the small incision and fit into our instrument. And once all of the pieces are removed, we remove the chocolate, the candy shell, the chocolate and the nut, we implant a lens. So that's essentially what modern cataract surgery looks like. Now, in the past, patients didn't have much choice. They came in and said, I need surgery, and the doctor told them what's going to be done. But today, our consultations with patients are much more involved. We don't have time to talk about all the things that I just talked about, but we do have very personalized conversations about what patient goals are. And everything I tell you here today is not meant for your medical advice. It's just for education. So we're not going to discuss what you personally as a patient should have. That you need to discuss that with your ophthalmologist. So today the conversation goes like, well, you want to have surgery, but what kind of lens do you want to have, and what are your goals? And there's three main types of lenses we talk about. There's something called a basic lens or a standard lens. And this is a lens that I personally use over 90% of my surgeries. There's also a kind of lens called an astigmatism correcting lens. We call that a toric lens. And we'll talk about astigmatism briefly. And there's something we call advanced technology lenses, which can give you more than some of these lenses. And we'll talk about those briefly. So what we call the basic lens, and this is usually the lens that's covered by most insurance providers, is able to correct someone's vision and get rid of the cataract, replace the cataract with this lens, and correct for nearsightedness or farsightedness. And this is the lens that I've had implanted for my family members, and this is the lens that we use for over 90% of our patients, or my personal patients. And it's a great technology, but there are some limitations with it, that it does not correct astigmatism, and also that you can only really have one focal point. You could either see far away or up close. Now, patients often say, well, what are you talking about astigmatism? Someone told me I had astigmatism, but you're telling me I don't, or you tell me I don't really have it, or you're telling me I do, and someone told me I didn't. Astigmatism is a very specific discussion that we have with each patient. Astigmatism essentially means, and I'll try and draw you a picture of what I often talk about with astigmatism. Astigmatism means that instead of your cornea being completely round, well, not too round like this, but it's round like a basketball, your cornea is a little misshapen. Let's say it's a little bit more pointy in a certain spot, or elevated, or that is astigmatism, and that can cause vision blur. One way to correct astigmatism is with glasses, and my glasses have astigmatism correction. Another way is with special astigmatism correcting lenses called toric lenses. And we use these lenses very often. Here's a picture of a toric lens. It looks just like that other lens, but you see these three little dots here. Those little dots have to line up with the amount of astigmatism. So it's an extra step we do in surgery. Part of the reason for that is to help line up this special lens. And these lenses are not usually covered by insurance. So something you have to discuss with your physician. But it's a great technology that I would certainly have in my eye. So I offer it to most of my patients who are good candidates. Next, there are special lenses called multifocal or advanced lenses or trifocal lenses. And you'll hear a lot of maybe advertisements about these kind of lenses. There's one's called a Panoptix, which has been out in the United States for a few months, and one that's called a Symphony, which has been out even longer. And the reason I bring these up, and I tell all my patients about both of these lenses, and I do tell everybody that this lens is a compromised lens, in my opinion. You are compromising some quality of vision for the freedom of not needing glasses as much. And some patients say, I don't want to compromise anything. I don't care. Just give me the glasses, and that's fine. And some people say, I hate glasses. I'll do anything to not wear glasses. Let's talk about these special lenses. And that's a reasonable thing to talk about. And it's a very personal discussion. They're very different, both of them. And I'm borrowing a slide that by one of our colleagues, Shannon Wang, who talks about the intricacies between these two lenses. And different ones are better for certain patients, and there's no one lens that's the best for everybody, and they all have some limitations. So it's an important conversation to have with your doctor if this is something that interests you. And this technology, I'm sure, will only get better and better, but this is what we have today, April 23rd. So let's talk about what else is new in surgery. I told you kind of what was done, what is done now, and what things are on the horizon or that we're kind of experimenting with at the moment. And then we can take some questions if we have. So there is something called laser cataract surgery. Patients often say, well, this is going to be laser surgery, right? Well, not really. Most surgery in the United States is still done without the laser, but we do have the ability to use laser at the time of cataract surgery. Some patients think they've had laser or think their family members have had laser, but they didn't. We use laser in all sorts of different ways in ophthalmology. Sometimes we do laser before cataract surgery, sometimes during, sometimes after, and these are all different kinds of lasers we use. So it's a discussion to have with your doctor. My personal opinion is that there are some parts of this laser surgery that are beneficial. Lasers are usually more precise and accurate. So that first step I showed you where we make an opening in the candy shell, on the left side here, this is the opening that a laser does. On the right side is when it's done by hand. The laser is almost always going to be more accurate in this step, and that's a nice benefit. But there's also things you need to consider, like cost and other downsides. There are new technologies called light adjustable lenses. Remember I said that everybody gets a special lens specifically designed for them, and that's the case. But those lenses that are designed for them and picked for them are based on their measurements, and those measurements are not 100% accurate. Sometimes we get what we call a surprise, where we say, we really thought you weren't going to need glasses at all, but you still do. You have a little bit of astigmatism, or you still have a little bit of nearsightedness. The goal of this lens is to be able to shine light at the lens that's already been implanted and change that lens's prescription. So this is a technology that's being used in some parts of America and in the world already, and things that we're looking into that we hopefully will be beneficial for our patients in the future. Dropless cataract surgery. You hear everybody who has, almost everyone who has cataract surgery needs to use eye drops. And the drops are the standard really of treatment of inflammation and preventing infection in surgery, but the drops are bothersome to some patients. There's a cost issue, they could irritate the eye, you have to remember to put them in. So what if we could put the drops directly into the eye? One way is to put it into the back of the eye with an injection of medicine. Another way is with implanting something in the front of the eye, like an implant that, like this, that slowly releases medication, or even implanting medication into the front, into the eyelid, into your tear duct that will slowly release medication. These are things that we're working on, and some of us have been experimenting with, and we hope that they could help our patients in the future as well. Another thing is 3D eye surgery. This is, if you look here, this is an operating room where you notice all the docs here are wearing glasses. These are 3D glasses, and myself, I'm operating sitting at the microscope wearing glasses, and all of us are looking at a screen that's over here that everyone in the room can see what we're doing. I don't have to lean in and look through the microscope. Everyone in the room can see what I'm seeing, and this is great for, I think, for teaching institutions, and there may be some benefits in our practice or other practices in the future as well. So that's the overall big picture, things I wanted to talk about. Let's see how we're doing on time here. Not bad. This is our practice. We have a few locations. Our main location is in Milford, and we also have our offices in Orange and Shelton, in Brantford, and in Westport. You could visit us online. You could visit us on Facebook and on Instagram. And I just wanted to briefly, I'm going to see if I can bring Dr. Meskin on. Let's see. Okay, so Dr. Meskin's not muted. He's on too. I don't know if you guys can see him. And maybe he has something to add, but I just want to share kind of what we are doing as a practice today. Well, let me go back to that slide here. What we're doing as a practice today. For the last few weeks, we've been mostly just taking care of our emergency patients and our surgical patients who needed follow-up. And we're developing protocols to try and find ways to safely take care of our patients, of our staff, and of our doctors. And every day is different, and we're getting to the point where I think soon we will have a good protocol. But some of the things we've implemented, first of all, we're going to be calling patients the night before and trying to get as much information as possible from them so that they limit the interaction with our front desk staff, their insurance information, try and collect copays and deductibles prior to their visit. We're going to try and call patients in from the parking lot on the phone so we don't have crowded waiting rooms. We're going to limit the amount of patients we see per day, per hour, so there's less patients in the office at one time. We're going to implement very strict cleaning techniques where after each patient leaves the room is cleaned with certain chemical cleaners that we use and let dry, and no patient goes in there until the room is completely safe. Everybody's going to be wearing masks, from the front desk to the technician to the doctors, and just as importantly, every patient will need to wear masks and gloves as well. So those are the kind of things that we are going to try and do. And let's see. I'm going to turn off the screen share here, and you guys see me. Let me see if we have any questions. Let's see. So one question here is, what can I do to delay cataracts, and are there any vitamins that I can take, and what can I do to delay them? Do you have any thoughts about that, Dr. Meskin?
Hi, good morning. First off, I hope everyone is doing well and safe during this pandemic that we're going through, and also compliment Dr. Voldman. That was a great talk. In terms of options, there are not a lot of great options to try and delay cataracts, and the truth is we're all going to get them eventually. Most commonly just as part of the normal aging process. But there are certain nutritional aspects and health aspects that can influence. So there are certain medical problems, diabetes, if you're a smoker, if you have to use steroids for certain inflammatory problems, all those things can result in a cataract growing sooner. In terms of nutrition, the best advice is that we find is just overall good nutrition, the things that we all know, having a healthy diet, do seem to be helpful, but they're not going to prevent you from ever getting a cataract. And so there's not been anything specific that's been found that's going to, that you could take as a daily supplement that's been found to stop it from developing ever.
Great. I'm looking here at the chat, and I realized that I must have had a small problem while I was showing you guys my screen, and I was drawing images on my screen. It sounds like that wasn't coming up. Is that right? You didn't see when I was showing those Rendia images?
I couldn't see the beginning, but when you were drawing some of the things, yeah, I didn't see an actual image. I could see your slides, I just couldn't see the image that you were drawing.
Couldn't see the images. So let's see if I can show that. Do you guys see that?
Yeah.
You guys do see my screen. So that's too bad. I was really trying to draw pictures of what I was describing, but if you guys want to stay on, I'll just show you again. This is the front of the eye. And if we turn the eye in this direction, what I wanted to show is the front window to the eye here. That's the cornea, the clear front window. The back of the eye, like I mentioned before, is the retina. And inside the eye is this lens. And the cataract is when this lens begins to get cloudy. Instead of clear, the lens gets cloudy. And what I was showing the surgery step by step was, like I said, we make incisions in the front of the eye, and we try and remove the covering of that candy shell. And then we use that instrument called the phacoemulsification, where we disassemble the lens into smaller pieces so that we can remove the bits of the lens via that instrument, remove them from the eye. And when that is done, we implant the intraocular lens through that small incision. And part of the reason why this is such a personalized discussion with your doctor is because we don't just look on this part of the eye when we decide whether you're a candidate for cataract surgery or what kind of lens implant or what kind of surgery you're a candidate for. We also look at all the other parts of the eye. So when we look at the front of the eye, we put drops in, we dilate your pupil, and we look at the retina. Here's what the retina looks like. This is what we see. We see these blood vessels, and these are normal in most. This is what they normally look like. We see this yellow-white thing here we call the optic nerve that we evaluate for glaucoma. We look at the center part of the retina called the macula, and we can zoom in on these different eye structures with certain technologies and imaging to determine what the potential visual outcome will be, whether you're a candidate for certain technologies. So those are things I just wanted to share. So let's see, any other questions we have here? Dr. Meskin, do you see the questions or are they just coming up on my screen?
I can see them under the Q&A.
You see them, right? Okay.
I think I see them, yeah.
Okay.
So here's a question that someone asked. What are the disadvantages of having cataract surgery earlier than potentially necessary?
Well, I mean, from my perspective, there is no well-defined period when a cataract's ready. Some people are aware of this term of a cataract being ripe or mature, which is, it's a decades-old term that used to get used when the technique involved a much more prolonged recovery period with much more uncertain results. That being said, for us, I think each person we look at as an individual and their individual symptoms, their individual needs. And if a person, even if they have what we would consider as a mild cataract, is having a negative impact on their daily functioning as a result of the cataract, then it's reasonable to be talking about cataract surgery. And I think that, again, each patient is different. So if you have someone that, for instance, does a lot of night driving, or perhaps they do certain sports or certain things like golf where they really need to track a ball going out at a distance and they're having a difficult time, and the eye is otherwise healthy and it's the cataract that's causing that, then it's reasonable to be talking about cataract surgery, even if their vision is not nearly as compromised as someone that has a very dense or very mature cataract.
Yeah, I completely agree. And also, we didn't have the discussion here about risks of cataract surgery, but there is no surgery that is without risk. And whenever you take on cataract surgery, you're assuming risk. And I don't think people would want to take risk if they don't absolutely need to. So it really, I think, is usually the patient's decision whether they want to take on that risk. Just because 98% of people do great, there's always that small risk, and that's why we take it very seriously. So that we generally don't intervene until it's absolutely necessary and it's going to improve someone's quality of life. Another question came up was, does being nearsighted or farsighted affect you when you get cataract surgery? So yes and no. As far as the actual surgery goes, not really. Maybe small techniques we do differently. People who are at the extremes of nearsightedness and farsightedness may have higher risks of surgery. But it can be part of a personal discussion. If somebody has been nearsighted their whole life and says, I love taking my glasses off to read, I don't ever want to lose that. Well, then you might benefit from having cataract surgery with a lens that allows you to read, and you need glasses for distance. So those are things that we take into account. Let's see, the next one here. Tom asked, you mentioned insurance doesn't cover toric lenses. What is the average out-of-pocket cost to go this route? Dr. Meskin, do you want to take that one? Or?
I think it varies across different practices, and because generally the reason that they're not covered is that these lenses are considered by insurance and Medicare as being elective, meaning if you're having cataract that's affecting your vision, we're treating the medical issue, which is clearing that lens. So when Dr. Voldman showed you that you have that cloudy lens, we're removing that and putting in a crystal clear man-made lens. When we do that, the bonus is that we're doing these measurements that then try and help reduce your prescription in some way that you've discussed with your physician, you've decided upon. And for nearsightedness, farsightedness, the nice thing is that that's pretty straightforward to cover with those monofocal lenses that insurance covers as standard. They're the gold standard. Toric or stigmatic lenses are considered cosmetic, you could say, or elective by the insurance company, so they don't want to cover them. And there are fees that come from the surgical center in terms of ordering that special lens for you. And then there are fees that come from the surgeon because there are additional tests and measurements that are done that are not standardly done, but are done in order to allow one of those lenses implanted. I would say that across the board, to try and give an average, generally per eye, because they're usually charged per eye because maybe one eye needs it, one doesn't. They're going to be somewhere probably around the $1,000 to $1,500 range that you would pay separate from what your the part that insurance covers the rest of the procedure.
Yeah, that's generally the range that I've also seen. So yeah, it's hard to give an absolute answer. Geographic location is going to change that, and practice preference. Another question here is, does having another issue being treated, such as a CRVO or something else, affect the decision to have cataract surgery or the risk? That's a great question. So this patient is asking, if I have a CRVO, which is a problem in the retinal vasculature or a central retinal vein occlusion, does this affect my decision to have cataract surgery? The answer is absolutely, it affects it, because there are different ranges of CRVOs. There are patients who could have a CRVO and probably not know it, very rarely. And there are people who could have a CRVO and lose vision completely to the point where they can only see light. So the visual potential is going to be very different, and it's often very hard to distinguish what you're going to really see after cataract surgery if you have both a cataract problem and a retina problem. So that's an important discussion to have with your doctor to make an estimate, to say, how much is this going to help you? Will cataract surgery help you? And is the benefit worth the risk? So yeah, that's a good question. All right, well, I don't see any other questions for now. I'll try and post this if we can get a recording to our Facebook or our YouTube. And as a practice, we're available for our patients. And we are here for you guys. And if there are other topics that you find interesting, or you said, this was a good discussion, I want to know more, send us a message on Facebook, on Instagram, and we can try and come up with some more lectures, and we can go from there. So I appreciate everyone tuning in, and have a good rest of your day.
Thank you, everyone. Be safe.
Be safe.